Good afternoon, everyone. My name is Mark. I'm working for Open Web Technology, a Swisscom subsidiary here in Switzerland. I've been working for more than 20 years in the data and AI field for a lot of different projects and industries. What I would like to share with you today is our lessons learned for our last projects, which is a patient triage application. Mainly, this is an app that you and I are using when we feel sick and want to make an appointment with a doctor. So you are going to describe what you are feeling, your symptoms in this application, and this app will recommend a point of care, meaning you have to go straight to the hospitals or you can just relax and book an appointment with your doctor. So as this application has been used for Swiss market, I will quickly describe what is the specificities of this market, and then we'll jump straight into the case. So the Swiss healthcare system is a system that has a lot of doctors and a lot of nurses. So we have good coverage in terms of health. On average, each doctor is doing 1,000 consultations per year. Generalists are accounting for 28% of the doctors available in the country. But the cost for this is also very high. It's about 12% of our GDP. On top of this, households are paying a lot of money that is not covered by by health insurances. They are paying up to 28% also of the costs of the healthcare. So we have a few challenges that may be similar to other European countries, which are depicted here. So we need to meet growing patient expectation. We obviously need to attract and retain doctors, increase productivity to reduce the cost. And we obviously need to adapt to changing regulation, which are quite often in this field. So with this in mind, our customer, Medgate, decided to implement a telehealthcare service. Today, I would like to concentrate on the triage aspects, and we developed a specific AI application for that is used by the patient. And as said in the introduction, you will use this app describing your symptoms and you will be directed to the right point of care. So it could be a teleconsultation if nothing is really important. You could be directed to a hospital because it's something that is urgent and that needs immediate treatment, or you can go to your general practice in case it's something that can wait a few days. So when we implemented this application, we already got two different types of outcomes. So the medical outcomes and the financial outcomes. So in terms of medical outcomes, what we noticed is that this app increased the quality of interaction between the patient and the healthcare system. Is it a self-service app? You can use it whenever you want during the night. You don't have to wait for the next day or call your doctor and get an appointment. Also, it allows scalability as it's an AI-driven application, so it can go beyond what human can do. And it is also able to detect abnormal measurements. So it could be for aftercare system that monitors the patient and detect if anything is happening. On the financial side, we were able to automate 25% of the patient's triage, meaning that they were directed without any human intervention. So this, of course, reduces the cost. AI support decision tool also reduces time to diagnosis and treatment, as you have this self-service and immediate response. And we were able to forecast and define the best treatment, reducing also cost, the major risks and the future costs, identify abnormal costs. That is also useful for insurance companies to evaluate how much you're paying and how you need to be reimbursed. So this is how we built this application. And as mentioned earlier, I won't go too much into the details of how we built this and what algorithm we used. I will rather concentrate on the test that we did, the trust that needs to be set between the app and the patient. But for you to understand how this is working, we will go a little bit here in the different steps. So the first thing that we need to do is to build the knowledge out of the historical medical cases. And here for this task, we had a lot of medical cases. We had 7.5 million cases that were created by doctors. So when you come and see your doctor, you sit down and explain what you have, and the doctor is typing in the system in text. I mean, it should be could be English, could be German, whatever, what you have. And these cases look like this. So you have a patient profile. It's a man, it's a woman, the age, and so on. And you have the patient case. And here we have a field that is reason for encounter that will explain, okay, why you came to see the doctor. So here it's a German text. So from this text, we have to use standard natural language processing tools, techniques, to first anonymize the data, because it's health data, which needs to be anonymized before you can actually use them. And then we have to recognize the different symptoms here. So, and the different timestamps, or the temperature, if you have fever, if you have more fever, less fever, what exact temperature do you have? So this is a huge work that has been done, trying to find the different symptoms from this pretext. And then also we need to map the symptoms to the actual disease, or, so we created buckets with similar cases, and then we try to map a case to a bucket. In order to do that, we have to ask questions to the patient in order to find the right bucket. So this is done through a knowledge graph. And the knowledge graph will decide what is the best next question to ask to the patient in order for the algorithm to have the highest probability to find the right bucket. But this has to do with probabilities, and it does not include any logic from the perspective of the patient. And what we have seen is that sometimes the best questions with regard to the probabilities are not well understood by the patient. And we'll come back later to this very important issue. Last but not least, we need to build a conversation engine on top of this knowledge graph. This engine will decide when to ask another question if he doesn't feel confident to issue a recommendation. So the recommendation is found here on the right side of the slide. So you have the different points of care. So telecare is a teleconsultation is enough for what you have. General practice, a specialist, or you have to go straight away to the hospital. And in the columns, you find the time to treat. Is it something that can wait, or you should immediately go to the hospital? So these are the two outputs of the algorithm. And this is driven by this state machine that you find on the left, which has to decide if the algorithm is confident enough to give its recommendation. As I mentioned earlier, this has to be tested with the patient in real world, because sometimes you can build the best algorithm in your lab. It doesn't mean that it will be accepted or used by the end user. And this is what happened in our case. So we are all used to do software tests, automated tests, to be sure that we have no bug, that everything is working. So this is what we have on the bottom right here. Also, very early in the process, we are used to test the application and be sure that the UI that we've built is usable and it's okay to be used by the patient. But what we have here on the left side and what we have created is this in vitro trials and in vivo trials. So I will explain a little bit what it's all about. The in vitro, we asked nurses and doctors to use the application with historical cases and to point out what was not working and to annotate weird questions or not, weird recommendation. So more on the professional side. And then we also exposed this AI tool to real patients to get immediate feedback of how they felt about one question that was asked by the system. So this is described in the next slide in a bit more detail. So how it worked. We used recordings of past teleconsultation and asked nurses to play back this file and pause the file when they heard a symptom. So it's a simulation how the patient is expressing his symptom, and we try to use this exact wording into our system to see how the AI was reacting. And here again, we found very weird behavior, like, okay, my foot is hurting, and the system was asking, do you have a runny nose? There is no logic. There is maybe mathematical logic. Maybe this is the best question to be asked if you want to separate two buckets. But the user, the end user, does not understand this. And if he doesn't understand, he won't use this application because he will say, okay, this is crazy. And then what we did is we did this in vivo phase 1, where we had real patients on the phone. So after their teleconsultation, we asked them if they were okay to participate in the survey. And the nurse was actually typing the answers of the patient and was reading back the question from the AI. So we got here a direct feedback, immediate feedback of what the patient was really thinking. So we could also detect weird behavior of the AI. One example is, okay, I have a pain in the arm. So the AI was asking, is it the right arm? And you say no. And then it will say, is it the left arm? And then you say no. And then the AI continues to ask questions. So it did not notice that actually this is not possible. So we had a lot of different cases like this that were identified, or that symptoms that were not understandable by patients, like very specific ones. Do you have a migraine? Migraine is something that is very specific and that cannot be understood by patients. You cannot make the difference between a migraine or a headache. So all these things changed the algorithm and actually lowered the accuracy of the algorithm, or we required more questions to be asked to the patient. So sometimes in order to have this trust, have this usability, you have to decrease the accuracy of your algorithm. So finally, the in vivo phase 2, we expose the AI algorithm directly to the patient, but without giving the recommendation. So these inputs were then used internally to tune the application. For this, we have implemented a new way or a new measurement assessment here with different hypotheses that we wanted to test. The most important one here was, can the symptoms be expressed easily by the customer or the patient? Meaning that either you type in free text and ask the patient what he's got. But this, we realized that was very difficult because people were, using different words for the same thing. So this is possible when you have a nurse or professional that is using the app because he knows the right vocabulary. In the patient's case, we needed to guide him with predefined symptoms. So he had to select between predefined symptoms. And this is the process here. Also, some symptoms in question are gender specific or age specific. And we have to be careful about this because, you know, some organs or some conditions cannot happen to men or women. You cannot ask a man if he's pregnant, or you cannot ask this question to a 6-year-old girl. So this is what happened also when we had to teach or to add business rules to the system to be sure that these questions were not asked. Question and answers are understandable. This relates to the example that I gave before with the migraine. So we needed to avoid this very specific question that the patient was not able to answer. The conversation has to be short. If you need to ask 100 questions, then you will lose the patient. He will never finish the process. Even though if you ask this 100 question, your algorithm will be very precise, very accurate, you cannot do it in the real world. Also, between the ideal world and the real world, there's some differences in terms of risk management. As a company that provides this service, you don't want to miss like emergencies. So you have to lower a bit the different thresholds in your system. So with this bias in place, of course, the accuracy is also lower than it could be in an ideal world. And last but not least, the patient are satisfied. Obviously, you need to measure if you have the satisfaction, if you have the trust of your patient in this application. There's a lot more that can be done with AI in the telehealthcare world. Most of these algorithms will allow for reducing the cost of the healthcare system, which is something that is hurting today the households, but also the shortage of medical people in the world. So we can improve prevention, the triage. Obviously, this was the case that I presented today. The scheduling, so the appointment optimization or the surgery orchestration during the treatment, the patient monitoring when he goes back home. So the aftercare, be sure that everything is okay, and in case raise an alarm and get him back to the hospital for additional check. So all along this way, this value chain, there's a lot of things that can be done with AI. So this was the lessons learned from our last project. So to be sure to include the final user's voice in the design of the algorithm, and this may lead to important changes, even change the accuracy or lower the accuracy. And this may sound counterintuitive, but actually this is what needs to be done if you want your algorithm to be used in the real world. The Open Web Technology is a strategy and technology consulting firm. We help our clients leverage new softwares and hardware technologies to reshape their business, invent new products, or transform their operation. And AI is a great example, starting with raw data, as we did for this triage patient app, and then manage this data, leverage them to build a smart web and mobile application. So I would like to thank you very much for your time. Don't hesitate to ask any question you would like. And last but not least, please use the chance you have to give us your feedback and review this session. Thank you very much for your attention. Have a good day. Goodbye.